Everyone, we're going to get started. I'm very pleased to introduce our speaker today, Dr. Jackie Wang. Dr. Wang is an associate professor in the Division of Hematology Oncology here at San Francisco General, and also the director of the Anal Dysplasia Clinic at San Francisco General. Dr. Wang has been enormously helpful with so many of our patients at Ward 86, and we're really excited to have her speak about anal cancer screening and treatment. So thank you, Dr. Wang.
Good morning. Thank you very much for having me. So I think I gave this talk maybe 2 years ago. Some of it is, very similar, but hopefully everyone will bring some, remember some of the stuff for your practice. All right. So I have no disclosures, but I will mention some off-label use of medications. So to talk about anal cancer prevention, I want to start with anal cancer itself. So what is anal cancer? It is cancer arising from the most distal part of the digestive tract. Almost all of them are associated with persistent infection with human papillomavirus or HPV. Most of these cancers are squamous cell cancers. And most of these cancers are caused by HPV-16. Probably 80–90% of anal cancers are HPV-16. So anal cancer include both cancer in the canal and perianal cancers. Perianal cancers are also HPV associated, and most of them are treated similarly to the cancers in the canal. So we are seeing a slow but steady rise in the incidence of anal cancer according to age. So this is data from the SEER database. So breaking down between men and women, the incidence rise is actually more striking in women, and these are usually elderly HIV negative women. Whereas in men, it's a bit younger, and a lot of this rise is driven by people living with HIV. So what are the risk factors for anal cancer? Usually it's related to HPV acquisition. So multiple sexual partners, history of anal warts or condylomas, history of anal receptive intercourse, and history of, in women specifically, history of cervical, vulvar, vaginal, high-grade squamous cell epithelial lesions or cancers. Tobacco is one. There's an interesting interaction between HPV and tobacco. And then, of course, impaired cellular immunity. So we're familiar with people with HIV, obviously, but then also, I also see people who've had organ transplants, kidney transplant being the most common one. What is the rationale for anal cancer prevention? So it's very similar to cervical cancer prevention. This is a cancer that usually, most of the cases are non-metastatic. They're usually relatively early. People usually have symptoms, pain, bleeding, and things like that. People don't usually ignore them, which allows us to at least, work up the cancer and find them relatively early. But this is a cancer, if you find them early, the survival rate is quite good. When they're localized, meaning just in the anal area, the 5-year survival rate is over 80%. When it spreads to the local lymph nodes, the survival rate does drop. It's usually in the form of the disease relapsing after primary treatment in the more distal metastatic sites. Obviously, if they do present with metastasis in the liver, lung, for instance, then survival rate drops significantly. But overall, this is a very survivable cancer. So that, give us more of an incentive and chance to try to find them early. But unfortunately, the treatment for anal cancer is not fun. I don't know if you have taken care of survivors of this cancer. A lot of them have morbidities associated with primarily the radiation. And it will last for the rest of your life, unfortunately. So of course, we want to spare them from having to experience that. So to prevent anal cancer, we have to find anal precancer, or HSIL, which is high-grade squamous intraepithelial lesion. The old nomenclature you guys may have seen more in the GYN world is sort of low, medium, and high grade, or severe, I should say. But we no longer believe it should be a 3-tier system. It really should be 2 tiers, just low versus high. In the previous level, grade 2 and 3 are lumped together as high grade. So that's based on so what we might have hear some of us talk about the new last terminology, the lower anogenital squamous terminology project, which is this change from 3 tiers to 2. It's not really a continuum. It's binary. And we try to, so instead of, CIN, AIN, PAIN, we just call them high grade, but then denote the anatomical location, make it a little bit more standardized, and then we really sort of tossed out the term carcinoma in situ. Our pathologists would never use that here, but you might see that on the pathology reports from outside institutions that have not caught up. But carcinoma in situ means HSIL. It's not cancer, it's pre-cancer, okay? So that's a common thing. I mean, as primary care doctors, if you ever see that, patient carry that diagnosis, just make sure they understand that. It didn't mean they have cancer, it means they have pre-cancer before. And a lot of patients, when they see carcinoma, they don't see the in situ part, right? They just see the first word carcinoma and then they assume they had cancer. So it's very important to make sure to understand that. So of course, the biggest advance in the last 5 years is the completion and publication of the primary results of the ANCHOR study that's led by Dr. Pulevsky here at UCSF. This is an anal cancer HSIL outcomes research study, and our primary aim is to determine whether treating anal HSIL is effective in reducing the incidence of anal cancer in people living with HIV. So we started with people living with HIV who are 35 years or older. They are screened to see if they have HSIL or not. If they have HSIL, they are randomized to either the treatment arm or the active monitoring arm, and then they're followed to see if they develop cancer or not. At any point, if they have cancer, they're referred for treatment and they exit the study. I mean, this is a major undertaking, as you can imagine. I think this is like an almost 10-year process, and I think close to $100 million of NCI money. Okay. So what is the primary result? I mean, the money shot is here. People living with HIV who are age over 35, treatment of anal cancer does reduce the risk of progression from HSIL to cancer, and we lower that risk by about almost 60%. So the risk is much lower if you get at least some form of treatment for anal HSIL. So this sort of, I think, seals, I think we're all very relieved in our clinic, our lives, years of work has not been in vain. We don't have to shut down our clinic. We at least prove that what we're doing is worthwhile. So once we prove anal HSIL is worth finding and treating, then we want to shift our focus to who should we screen. So we talked about the risk factors before, and these are. This is a meta-analysis of multiple natural history studies, and then we break them down to these risk groups, and then we're trying to find the degree of risk for each of these risk factors. And I think clearly the winner is HIV infection. Like just having HIV, increase your risk significantly. I mean, your risk does get lower when you're younger. And then age, matters here, obviously, but by far, HIV is the most significant risk factor for anal cancer. And then next is, having sex with men. And then other sort of GYN-related factors are less. I mean, the relative risk is much lower. And then finally, some of the other immunosuppression that we talked about. So it's a bit of an artificial line, but we decided to mark it here. So basically we decided anyone who has a risk of anal cancer over 17 per 100,000 person years should we should recommend screening. And then everyone else whose risk is below that, it's a shared decision-making, meaning you should talk to your patient, similar to how you approach prostate cancer screening. Yeah. So most, as you can see, most of people who fall into this are people living with HIV. And then some of the older men who have sex with men. So once we decided who we should screen, the next step is how we should screen. This is then again, a little bit the data could be stronger, but we do have some limited data. So mainly we have two screening tests. One is cytology and one is high risk HPV. And we can also combine them together. Here at UCSF, you have to do two separate swabs, one for the cytology, one for the HPV test. At a lot of other places, you can check the HPV test for both on the anal swab, meaning you only need to do one swab and you can do both tests. And the HPV test also varies. Like usually, some of them only report they have 16 or 18, and others would just say they have some sort of high risk HPV. So you just need to know what your lab offers. So let's start with our first case. We have a 39-year-old man living with HIV who presents for regular follow-up. His HIV was diagnosed at age 32. His risk factor was men who had sex with men. His C4 nadir is good, it's 400, and he had no history of OIs. No prior anal genital condylomas or other lesions. He's compliant with antiretroviral therapy with undetectable viral load. He's currently have no anal symptoms. So what is the appropriate thing to do for anal cancer prevention at this point? You guys have the audience participation? Okay. Okay. Okay, well, I mean, it's good. Everyone knows what I was trying to get at. So remember, and he is older than 35 and living with HIV. So the guideline is to recommend doing anal cytology now. And he is appropriate for screening or prevention because he's asymptomatic. If he has any anal symptoms, then you should think of what you do as more of a diagnostic procedure rather than screening. Do I go? Okay. Sorry. Do I click or just more? Oh, there we go. Thank you. Okay, so now we have this algorithm. You can find this from the clinical guidelines from, I think, this is from the NIH, right? Yeah, this is from the HIV.gov website. So they do want, so this is not a question for us, but if you go to a place where you're not sure if they have HRA, you should probably find out about it because, it is, you can't really screen with HRA if you don't have access to HRA. And that's still true for a lot of places, particularly in the South. I think on the two coasts are pretty good. And then in the Midwest, like Chicago is probably the best one we know. I know a lot of places are trying to build this capacity, but it is challenging because, HRA is not currently included in any residency or fellowship training. So we're hoping we could establish a fellowship here, but it's a lot of work, and if people are interested, definitely at least start with an observation with us. A lot of people who started doing this, start with the observation with us, and then there is a workshop we do. Also, I think every year that includes lectures and a little bit of hands-on training. And then eventually most people just have to start doing this on their own. And then just the more you do, the faster you get better at it. So But basically find out if you have HRA, and then you could start with a digital anal rectal exam, and then cytology. And then here, did you only do cytology, or was your HPV test? I really do. I think given our still relatively limited capacity, the more information we have, the better we can triage the cases. But in general, if you have cytology and high-risk HPV, this is the breakdown. So if you have normal cytology, regardless of HPV test, usually you can just repeat the testing. The risk of anal cancer is relatively low if their cytology is normal. If they have ascus, then they have high-risk HPV, usually HRA is recommended. If you have an LSIL or higher cytology, that's LSIL, ASCH, and HSIL, those are relatively less common. They should just get HRA. So what happened with our patient? Our gentleman has LSIL. So if you remember to that guideline, he's referred for HRA, which is appropriate. So what is HRA? So this is one of our exam rooms at Mount Zion. So you have the colposcope here. This is the same colposcope gynecologists would use. You want an adjustable table. And then this is where we put the machines for treatment. And then we always want a computer there because we want to have full documentation of our exams. That way we can compare from visit to visit. So this is our exam table setup. We need a lot of swabs, vinegar, Lugol's or iodine, anoscope, and a lot of lubricant. I like to have just Surgilube with some lidocaine ointment. This is how we start an exam. And so our first step when we train is we have to recognize the squamocolumnar junction, and that's this line here. Okay, or this part. A lot of times just by applying more vinegar, we will see this line more clearly. And you get a sense of how far in you have to go. Like in general, men have longer canals, so you have to go in a little bit deeper. And in a lot of women, their anal canal is quite short, so you don't need to go in that far at all. This is a good representation of a normal looking epithelium, anal epithelium. And then we could further establish it's normal by applying the iodine or Lugol solution. When it stains brown like this, that's normal. Oh, okay. I mentioned the guideline earlier, but they're trying to, when capacity is really limited, we want to further, stratify the risk if possible. So how we try to prioritize patients, that's why I really want the HPV test, because, clearly if they have HPV 16, they by far have the higher risk for anal cancer. So I need to know that. And then there are some places, if their capacity is so limited, even they just are going to choose, HRAs on people who had HPV 16. Everyone else sort of take a back seat, unfortunately. And some other more minor factors that could help you prioritize patients, smokers, people older than 60, people living with HIV for a long time. Because as if you remember, the risk of anal cancer risk does increase as you get older. So that was normal we saw earlier, and now this is example of what HSIL looks like. So this is what we call lacy metaplasia here on the left. So it just sort of looks like, I don't know, like tablecloths or things that look kind of lacy, somehow I sort of remember. And then they should stain yellow with the iodine solution like this. This is a really good example. So next question, once we find HSIL, how do we treat it? We have a few options here, surgery, electrocautery, topical medications, or all the above. Okay, so yeah, most people got it right. They're all options. they're all options. I'll talk a little bit about what is common. Sorry, this is happening to me again. Oh, did I go? Okay, there we go. Sorry. Okay, so I'll start with the topical treatment. Some of this you might be familiar with, like imiquimod or 5-fluorouracil or 5-FU, or also called Fudex cream. So these are also used for warts and sometimes for other skin conditions like actinic keratosis or something. So these medications work by stimulating the body's immune response, especially imiquimod. So if you have a relatively young person or someone who is HIV negative, you might really want to consider starting with imiquimod. And then the one you see me use most commonly in the office is electrocautery. I don't use laser ablations here, but gynecologists do. So these techniques use heat energy to destroy the abnormal cells. And then there's, of course, surgical excision, especially if there are large lesions or if there's any concern for cancer, you want to excise that rather than just ablate it. So this requires a surgeon who has access to high resolution endoscopy. That would be highly recommended. So I can't do that here. I don't go into the office or the OR with our surgeons here, but so I would tend to refer like obvious warts to the surgeons or if there's an obvious mass. But at Mount Zion, I think we have a better workflow now. I think we have been successful at getting some of our patients over to Mount Zion for surgery, if indicated. I do need the primary care doctors and the nurses to help me with the insurance authorization and things like that. But in general, that process requires the patient to be seen by the HRA provider at Mount Zion on the pre-op visit, and then they get surgery the next day. So I think we've done quite a few cases that way, and it's been successful. So we do have good access to that now, I would say, but obviously we have to use it selectively. Oh, and sometimes we combine them. Like if the lesion is very large and the patient is willing and able, we might start with the topical treatment and then treat any residual lesions with electrocautery, or we could do surgery first and then do more electrocautery later. Or sometimes though they would do 2 surgeries. Like they would use the first surgery would treat like 60% of the lesion, and then the second surgery would treat the rest. So these treatments could be combined together. So this is an example of electrocautery. So this is the machine we use. And you can see the tip is tiny. So obviously that's why we can't treat a very large area if the lesion is large. But this is here what the lesion would look like after it's treated. So some of the less commonly used options, occasionally we use TCA or trichloroacetic acid or podophyllin. You might be familiar, we use this for warts as well, but it will destroy HSIL. So obviously smaller and flatter lesions, you might consider this. And of course, same thing with a dermatologist, you can use cryotherapy. But obviously, it's a little bit, right now we don't even have TCA here, so we can't really do it, but I would like to. And cryotherapy, of course, yeah, you can obviously do that, but then of course you need to have access for it and maintenance of that. So some of the factors we use to choose the treatment, size and volume of the lesion, location, whether it's inside the canal or in the perianal area, what is the person's functional status and immune function, and then their preference and tolerance. Because for instance, I think this is probably really important for the topical treatments, because patients have to apply it themselves. So they have to be able to insert their finger inside the anus. They have to feel comfortable with that and be able to do it consistently. So, it takes some education on my end, and then really assess if I think the patient will be able to stick with it, because the topical treatments takes at least a few months to achieve full effect. So, if I consider all the options that I could personally offer and do, and then but then there's a concern that, I've had patients who occasionally I try the treatment, but the patient bled quite a bit. So I may want the surgeon's help with that, because they're better equipped to deal with and manage more severe bleeding. Some patients are really uncomfortable exams. I try not to use that as the reason to utilize the surgeons, just because I don't think it can be done consistently. Like, obviously we can't do screening for them over years using the surgeons to, put them under anesthesia. But they're occasionally, like, if I'm really concerned about the cancer and I couldn't successfully biopsy them in the office, then I would, use the surgeon for that. And of course, the most common reason is the lesion is just too large for me to deal with in the office, at least initially. So, sorry. So this is now our second case. This is a patient I met at UCSF. He's a 53-year-old gentleman living with HIV, had remote history of OIs, including KS and cryptococcal meningitis. But by the time I met him, he's been well controlled in terms of his HIV for more than 10 years. So he had been with us for a long time. He initially was seen by Terry Marcotte over 10 years ago, and then had these very concerning, by the time he got to us, referred by Terry Marcotte, we saw him and he had very concerning HSIL lesions that we were quite worried he may have an early cancer. So this is some of the representative pictures. So you can see this is similar to the HSIL picture I showed earlier, but you can probably tell it's a little bit thicker than the other lesion. So that's a concerning factor. And then some of these other areas, so this is what we call punctations from atypical vessels, sort of the redness of the bleeding spots. And the lesions come pretty big. Like you can see, start from the inside and come all the way out to the perianus. So he was, appropriately referred to our surgeons, and thankfully all his biopsies in the OR showed high-grade HSIL only. There's no cancer. So he was pretty aggressively treated multiple times over the years. And then I last saw him in 2018. This is his exam. This looks pretty good, about as normal as you can get. But then, I think with COVID and, whatnot, I didn't see him for about 2 years. And then he finally came back in 2023. He didn't have any symptoms, but again, you could see this is not totally different, right, from the exam a few years ago. We have very similar spots to, it's similar to where he originally presented in 2013. So I knew he at least had pretty widespread HSIL, but does he have any cancer? So we had to refer him to a surgeon. These are some more of his pictures. So we refer him to the surgeon again. He has some delays in getting there, but finally he got to the OR. He didn't have cancer, just a lot of HSIL, and he again was aggressively ablated. So that's our second case. And then our third case, a 49-year-old man. I started seeing him in 2017 for Ask-H cytology. So Ask-H is indeterminate. So sometimes you could see HSIL with it, but in this case, I've only found the anal wart, and he was treated with cautery and triclosan acid. He did well. And 5 years later, I thought his exam was essentially negative. But then he started having anal bleeding. He had a colonoscopy that just showed hemorrhoids and diverticulosis. And then he had pelvic pain. So when I examined him first in the office with the digital exam, I clearly felt an induration, but it was pretty proximal in the canal. So I could just barely catch this when I do the endoscopy, but I could see evidence of bleeding, and that is sort of the location where I felt the induration. He is HPV-16 positive. So after that, I sent him for an MRI. They actually saw some hyperenhancement in the canal. It's described as a possible ulceration. There's no fistula. Because he had a colonoscopy, but I knew there's a lesion sort of in the rectum rather than probably in the canal. So I got the GI docs to do a flex sig, and they found a friable area that they biopsied. The biopsy was probably a little bit shallow, but it did confirm it was at least high grade or AIN3, and there's colonic crypt involvement. So what would you do when you see this? The gentleman would, there's finding on the MRI, and the biopsy right now shows at least high grade. What would you do? Okay. Okay. So, yep, most people did what I would do, refer to surgery. And the other options are, I mean, for instance, repeating the biopsy is reasonable as well. But I think the key is here, you have to, so HSIL, you're not supposed to feel as an induration. If you feel an abnormal exam on with your finger, there's something more, because HSIL, the skin, it should feel like, just regular tissue. So if you feel some abnormality, it's probably not just HSIL, so you have to have that as a red flag. I think the key is, since it's not clearly just HSIL, you have to get at the tissue again somehow. And is that with a surgeon, or is that with a repeat flex sig? I think either one is reasonable, depending on which one you think you could get faster. So for me, I actually asked the GI docs to see him again. And here they got a little bit better. Our pathologist was able to say they probably could call it a squamous cell with some foci that's very suspicious. So with this result, I was able to get him to medical oncology and radiation oncology. And we did staging scans, chest, abdomen, and pelvis. There's no metastatic disease, thankfully. The lymph nodes and the other organs look normal. PET-CT confirmed that. There's no regional lymph node spread. So hopefully he's a stage 1 cancer. And this is the standard treatment now for anal cancer that's not yet metastatic. So this is a combination of chemotherapy with radiation. It's usually about a 6-week regimen. So they get chemo usually in the beginning and toward the end. I mean, the difference whether they get 5-FU or they get capecitabine, because if they take capecitabine is a pill, they would take that every day, Monday to Friday, on the days they're getting radiation, because it's a radiosensitizer. So this is pretty standard first-line therapy. Oh, I think, yeah. So, I mean, I think a follow-up for that patient, at least, is he did well with the chemoradiation, and he's still relatively early in his surveillance, but I believe he's cancer-free at this point. So that's, I mean, I felt bad I didn't catch his cancer before it happened, but, at least we still caught it relatively early, and he was a patient who didn't ignore his symptoms. I mean, and we also see a lot of patients who are misdiagnosed, that they thought they just had hemorrhoids or something like that. There are some cancers that could look just like a hemorrhoid, because I don't know if it's the invasion underlying the submucosa. It does sort of push the mucosa outward, so they could get sort of like a prolapse, and that's often mistaken as just a hemorrhoid. And sometimes the pain and the induration from the cancer is mistaken as thrombosed hemorrhoid. So just to, I mean, chances are it is a thrombosed hemorrhoid in like 90% of the time, but you kind of have to at least think about, could this be cancer? Especially if you treat them as hemorrhoid and they didn't improve, right? you can, it just, that I think that's true with any clinical scenarios. If you can assume it's something common, you've treated it as that, and the patient didn't get better, you just have to think, is there something else that I'm missing? All right. So then I think this is my last slide, the take home points. So the anal HCL is the anal cancer precursor or pre-malignant lesion. The purpose of anal cancer screening is to identify who could benefit from HRA to diagnose and treat their anal HCL. HPV-16 accounts for most of the anal cancer cases, and also a lot of the more difficult to treat HCL cases. So these are HCL that's multifocal or very large lesions. When there's concern for anal cancer, repeat biopsy may be needed, especially if the initial biopsy shows HCL only. We do have a reasonable amount of options for HCL treatment now, topical, ablation, or surgery, being the most common categories. But as you can remember from the Anchor study, treating anal HCL lowers your anal cancer risk by about 60%. So it's glass half empty, half full, right? Could we improve that? Can we lower that risk even more? And I think for us to do that, we have to get better HCL treatment, because I suspect a lot of what's happening is right now our HCL treatment requires someone like me to identify every single HCL lesion that's there, right? And try to gather all of them. But that's hard, right? Because we might miss something. So if we have a method that could treat all the HCL without us having to identify it, so I'm usually thinking, is there some form of systemic therapy we can give these patients? Then hopefully, we can lower the cancer risk even more by having a newer and more effective HCL treatment. So that's something we're working on as well. Okay, that's it. All right. So questions?
No, that was fantastic. Let's see, we have some questions in the chat, but we'll start with the audience.
So Jackie, I think that was a great talk. The question was, someone challenged me recently from another clinic, like a medical director of another clinic in Boston, saying, but there's not really, the Anchor was the right study in terms of what to do if you see dysplasia, but the evidence for screening, the evidence for just anal paps is not as strong. And of course, how would you even get there to know that you have dysplasia without that? But I just wanted to see your thoughts about that.
Well, I guess so. Anchor study shows you should find HCL and treat it, right? So, I mean, I guess it's an inference that if you have to find HCL, you have to do something. It's not just going to walk up to you and tell you that's what's happening, right?
But this big clinic in Boston has decided not to do regular anal.
Really?
paps. Yeah.
Okay. Okay. Is it because they don't have good access to HRA,
No,
or
they just think that
they
they
just-
don't have the evidence.
Okay. Okay.
Which
Well,
you're right. How do you get?
yeah. How would you
I'm just-
find HCL
I'm just
otherwise?
curious where that
Yeah.
comment would even come from a clinic director in a big
Yeah, that
equivalent clinic in
seems-
Boston.
Yeah,
Okay.
yeah, I'm not sure I have a
I didn't
great
know
answer.
where it came
It
from either.
seems obvious to me if you have,
Yeah.
if treating HCL is beneficial, then it makes sense you have to go and find it, right? So if you don't do anything, how would you find it?
And
Yeah,
then
it's
one
not,
other-
I
one
mean, if
other
you're waiting
question.
until people with symptoms, that's not really screening
No, then
anymore,
we're really
right?
past.
Yeah,
but it's
yeah.
very interesting, their policy, and they've decided not to do regular, and this is
Wow.
the Brigham Clinic. So the second is HPV. It just feels like you can extrapolate from the cervical cancer literature that if you have high grade HPV, you should move on to have more aggressive.
Well, I think
came
that-
up with one of Grace's patients.
Yeah, I do disagree with that a little bit, because
Can you
clearly,
explain? Yeah.
clearly there are a lot of people with high risk HPV that doesn't have HCL.
Okay.
I mean, I think the chance that's especially true if it's non-16 or 18 positive. Those people really don't have a significantly elevated risk, in my opinion. So
if it's 16 and 18?
if they're 16 and 18, I would be more inclined. And honestly, most of those patients, it's unusual for them to be negative cytology. They often have something on their cytology.
Patient was positive cytology, negative dysplasia.
Wait, hold on one second. Let's get the case.
Yeah.
If Grace, you could summarize.
Yeah, I think, I'm sorry, my initial thought would be, you don't have to do HRA right away, but you probably want to repeat the cytology in 6 months or a year if you're, slightly more concerned, because chances are on the repeat cytology, you'll get something abnormal and they have positive 16 already fairly recently. They still.
Yeah, so I think I have a question of sort of in the setting of limited HRA capacity, for how do you view a patient who's high risk, like HPV 16 positive with normal cytology versus like abnormal cytology, not HCIL, but like abnormal cytology with negative HPV, which one, I guess, would you prioritize for HRA? If you in the setting of limited
Yeah, I
resources?
mean, if that's their first result, I will probably be okay with waiting on both of them, at least for 6 months to a year. Yeah. I mean, just because in the anchor study too, some of these patients are followed for years, without their age still progressing. So at least a short-term observation is not wrong.
Okay.
Yeah.
Thank you. We have a bunch of questions in the chat, so I'm going to ask a few of them. Dr. Chimi is asking, Dr. Wang, can you comment on your thoughts of the relative efficacy of the different treatment options for HCIL lesions?
So yeah, I mean, it's hard. It's a heterogeneous population, so it's hard to say. Like, oh, sorry, is that me or? I'm gonna turn it off. Oh, sorry. So it's hard to compare between methods. Sometimes is it? Well, you have to make apples, right? Sorry. So yeah, so there's no one method that's perfect and suitable for every scenario. So it's just supposed to be personalized, right? You have to use hopefully the best treatment for that person. So I think you mentioned some of the factors we use to decide, like how big is the lesion? Am I concerned for cancer? Is how willing is the patient, to insert their finger inside the anus, those questions. So usually you go down sort of, I mean, I think that's what it's good to have this repertoire, so you can think about various ways that you can, best treat the patient. But this is definitely shared decision-making, right? You have to, talk to the patient and see what they're willing to do and what you're able to provide. Okay.
Sorry about that. Okay, so one question here. Do you find that imiquimod is effective when used inside the anal canal or more when used externally?
Yeah, so that's where the off-label use comes. I think on-label is supposed to be external use only, but in our experience, internal inside the canal use is appropriate. I think it is effective. Patients do have to use it appropriately. So what I tell my patients is, I obviously use gloves, and you don't want them to insert their finger up to the knuckle. It's really just about halfway in, because that's the difference between reaching the rectum versus the anus, right? If they put their finger all the way in, they're most likely applying in their rectum, which is not needed. So that I think how far in they go is one thing. And usually I will only offer this for patients whose disease is pretty almost circumferential or has a big surface area. So in that case, I tell them they really have to use both hands, because you can't really use one finger and cover 360 degrees on your own. So usually I tell them to use one finger to try to cover about half of their canal, and then use the other finger to cover the other half, and then try to sort of distribute it evenly throughout the canal. That's the way I tell patients to do it. Yeah.
That just made me think. So tips for the annual DARE for the primary care provider.
I mean, the first thing is do them, because the more you do, the better you'll get. You'll start to get a better idea what skin tag feel or papillae feel like, what do warts feel like, what do hemorrhoids feel like. I mean, sometimes, you see I do it and I was like, oh, of course it's that. But that's with like how it means I probably I've done thousands of theirs by this point, right? So that's the difference. You have to do more of it, to get better at it. So do them. I mean, obviously, I think I have the benefit of doing the dare and then being to visualize with the anoscope, so I could sort of self-correct, and that's the kind of feedback you need, right, to get better at something. So I know you guys can't do that, but I would encourage it. I think you guys can do simple endoscopies, right? So at least try, like, see if you could see if you have the time, do it there, but then try to see if you could find hemorrhoids or warts even when you do a simple endoscopy, because you can see some of that simple endoscopy. So at least try to get that yourself the feedback of doing the digital exam and then being able to visualize it and see if you're correct. So.
And then this is another question. So I have a good number of patients who have a history of abnormal anal paps that were referred to HRA years ago. Then they stopped at some point for unknown reasons. So I guess this is a general question. If a history of abnormal anal paps or need for HRA, would you change what you do with the new HRA results?
The new cytology.
Yes, I guess the new cytology.
Yeah, because I mean, even patients, we obviously have some patients at Mount Zion that we're following for 10 years or more. And so we're trying to come up with ways to return these patients back to the PCP, because that's what gynecologists do, right? They don't continue the patient on COPO follow-up forever, right? So you have to think about, when is the patient's cancer risk hopefully lower or low enough for the PCP to follow them again? And so one thing we use is how long ago, right? If we follow them for somewhere between 2 and 5 years, like our experience is that usually ACIL could be persistent for about 2 years. And that's the idea, that's probably how long it takes for them to clear the high-risk HPV infection. So if they do clear the HPV, and then you follow them for a few more years after that, and there's nothing popping up, you could probably sign them off and hand them back to the PCP. So if you tell me someone has HSIL 10 years ago, my first question is always, have you done the cytology again? Because I'm really not going to chase something from 10 years ago. We have no idea what's happened, right? I mean, oftentimes they probably clear the HSIL, right? Because otherwise they may have cancer by now. They hopefully aren't asymptomatic and everything. So if they've been asymptomatic and their HRA was 10 years ago, they're probably okay. You just need to restart the screening. Yeah.
And one last question. So my patient living with HIV meets criteria for screening. The screening is completely negative. Do I continue DARE annually and then do another co-test in 3 years, or do I have to keep co-testing annually?
I don't think we know. If they only had one cytology and HPV that's negative, I will probably at least do another one in 1 or 2 years. Okay. But I mean, I know the guidelines say it could be, you can wait up to 3. I mean, I think it's variable. I feel like if you're a young person, if they're 35, I may be more willing to wait the 3 years before repeating anything. But I feel like older patients, which we have a lot of here, right? We have a lot of 50, 60-year-olds here who might not have had anal cancer screening for some time. So I feel like if they're just starting anal cancer screening at age 50, I will probably do it more regularly, like annually. Yeah.
This was great. Any more questions from the audience? Okay, thank you so much, Dr. Wang. We appreciate this. And also next week, we're going to have Dr. Shimowski and Dr. Abelman come from the VA to talk about cases from the VA. All right, see you all next week. Thank you.
Yeah, feel free to